helping out delivering a presentation today aimed towards FY1s on the title of the Breathless Patient. And this is part 10 of the Mind the Bleep FY1 clinical webinar series that takes place every Thursday. So my presentation is essentially how, as an FY1, we can be kind of slick at assessing and managing a breathless patient and what kind of different things to look out for on our day-to-day wards, GP, ED, AMU, and different clinical scenarios. In my presentation, so I'll be covering what the structured approach to assessment, kind of talking you guys through the focus history, how to do kind of A2E assessments, red flags requiring escalation, most common cases that you guys will see as an FY1. And also, I've just added a bit on the structured approach to ABGs. And I've included oxygen therapy and delivery devices as well, because I feel like in medical school, for us personally, that was kind of very undertaught. And I'm currently at the respiratory ward, and I'm struggling a little bit with, understanding essentially what the different types of oxygen therapy devices are and what are the indications for that, and when you switch them over to which one, etc. And then again, I just made immediate management templates for differentials, just kind of quick ones to run through. So essentially, you're in your on-call shift, you're asked to review an acutely breathless patient on the respiratory ward. This isn't like a case study just yet, but this is kind of just to get you guys thinking of, where you might encounter a breathless patient. Here's an A2E, focused A2E on what you would do. This is not kind of the full A2E, but I've included main points on what to include in, doing the A2E assessment for your breathless patient. Essentially, airways, you want to make sure, is the airways actually patent? Are they having noisy breathing, and are they talking in full sentences? Big red flags if they're not able to complete their full sentences or not able to, speak at all. In your airways, also assess for any secretions. Is there any aspiration? Have they aspirated before? And are you hearing any snoring noises? And what's their GCS like? GCS less than 8, again, that mnemonic to intubate. Again, so airways, ensure that it's open, it's patent. And then next, you move on to the breathing. So first thing you want to look at is what their saturations are, like what is their actual, oxygen saturations are, and what's the drop that has occurred, if there is any. What's their breathing rate? Count their breathing rate, and try and figure out, are they actually, their breathing rate might be high, but are they short of breath? Are they gasping for air? Or which might appear like it, but also assess if they're actually using their accessory muscles to breathe or not. Then you move on to the chest examination as part of the A2E. Circulation, you look at their blood pressure, their pulse rates for any tachycardia, or any bradycardia as well. Cap refill time, ideally less than 3 seconds. For circulation, you want to look at their legs and their JVP for any kind of signs of fluid overload as well. Disability, you want to look at their GCS, what their BMs are like, and if they've got pinpoint pupils. If they are, for pinpoint pupil example, too many sedatives, too many opioids causing you to have these pinpoint pupils, and is it at a point where it's causing respiratory depression as well. Exposure, again, looking at the legs, if there's any edema, and calves to see if there's any kind of, are they hot, red, swollen, any kind of tenderness as well. Look at their temperatures to see if there's their infective cause, potentially showing for their breathlessness, and again, abdomen as well. Key focus, so we've done the A2E, but I just wanted to kind of focus on the chest examinations bit and what common things you guys might encounter. When someone's short of breath, they've got a high respirate, we figure out if they're actually using their accessory muscles or not, because that really changes the severity of it. When you auscultate the chest, most common things that you will hear would be a wheeze, crackles, decreased air entry, or more severe things like, in kind of rare extreme end of scenarios, if they're, if they've got a stridor, or essentially, if they're pushing towards the end, absent breath sounds. Um, Saturations. So they might not be on oxygen, and now they could have desaturated, and now you kind of have to apply oxygen to them, or they could already be on oxygen, and now that they've desaturated, you want to look at the level of desaturation. So, for example, if they went from 1 liter to 2 liters, or if they went on from 1 liter to 8 liters, that's a massive jump. So just have a look at those trends of oxygen saturations and also the requirement as well. Again, peripheral edema, looking for overload, like I mentioned. JVP and edema, big red flags for right heart strain. Again, calves, like I mentioned, and also do a cardiac exam as well. Just, looking for any kind of your heart sounds, your pulse rate, any AF, most common ones, and also any kind of murmurs or anything like that that you guys can see. Looking for, so in your A2E, when you do your pulse rate, you might actually get more of an indication to see, is there an infective cause to this breathlessness? So they could have a temperature, they could be sepsis indicators. So is their blood pressure starting to become more hypotensive? And are they in a bay where is potentially COVID flu exposed? And are they a frail patient? Because then that means that they've got this viral infection that, they're quite frail to like deal with it, and that just makes them, their immune system not as strong. And yeah, immediate red flags to escalate would be, again, airway compromise, respirate of more than 30, oxygen saturations of less than 92, a silent chest if the person is looking cyanosed, if their cap refill time is not filling up and it's taking more than 3 seconds, or if they're looking blue, or if they're looking very pale, and if their conscious levels have altered as well. Big red flag, kind of causing you to escalate early on. So whenever you go and see the breathless patient, you can either, depending on how they look, you might want to have a quick chat with them, take a focus history, or you might just want to go straight to the A2E if they're quite clinically unwell, look at all their obs, do the chest examination, look at all any kind of signs. In terms of taking a history focused at a breathless patient, you want to know, is it sudden breathlessness? Is it a gradual change in breathlessness? Were they always kind of short of breath and now they've become acutely short of breath? Or is this their first time becoming short of breath? Associated symptoms, you might want to ask for chest pain. Are they wheezy? Are they having any palpitations? Do they also have a cough? Are they coughing up any blood in their sputum? And do they have any peripheral edema at home, if they've ever noticed? When they say chest pain, it's a good idea to kind of ask them specifically, are you having pain when you take a deep breath in, or is it more the chest tightness? Because that, a lot of the times in COPD and asthma, patients will say they've got quite a high, their chest feels very tight. They won't say they've got pain on breathing in, or they might actually say that, but most common they'll say kind of, oh my god, like my chest feels quite tight. Pleuritic chest pain, common in pneumonia, also in PE, and orthopnea. Depending on where you are in your clinical situation, like for example in the wards or GP, just ask them, have you ever, having shortness of breath at nighttime, gasping for short of breath, gasping, sorry, in the middle of the night, just, gasping for air. Is there any aspiration risk as well, causing you to, become short of breath and, having those risk factors for having that aspirated pneumonia? Social history, ask for smoking, any drug use, what their baseline is like, and if they are, if they were short of breath, could walk about a mile, but now they can barely make it to the bathroom. Things like occupation as well, if they've got any occupational risk factors. In their past medical history, look for risk factors. So COPD, if do they have a known history, again, ischemic heart disease or heart failure, and what are their risks of PE as well? Again, very classic recent surgery, travel, immobility, and also just do a systems review if you have a time, and then you can come back to that as well and do the family history. Immediate investigations to just, bloods, routines, FBCs, USNEs, CRPs, depending on what you're thinking, D-dimer, if you're suspecting a pulmonary embolus, troponins, if you're suspecting, cardiac causes, ACS, acute ACS, or BNP, if you're thinking, pulmonary edema as a result of heart failure, ABGs, chest x-rays, glucose, and lactate. ECG as well, if you think that, especially if they've got a significant cardiac history as well. Whenever someone's short of breath, we automatically kind of lean towards the respiratory causes, but it's very good to keep it broad and think of cardiac causes as well at the same time. This is a case study. So again, you're on your on-call shift. You're asked to see a 73-year-old male that has become quite short of breath and is acutely desaturated to 83% on room air on the respiratory ward. When you get there, you do a quick A2E examination. You can see that the patient, let's call him John Smith. John can speak to you in short sentences, highlighting that his airways are patent, but his rest rate appears to be 30. He is visibly using his accessory muscles to breathe, and on room air, he's sitting at 83%. When you auscultate his chest, he's quite wheezy, and he's also saying that his chest is quite tight. You find out that he's a little bit tacky, 112 beats per minute, but his blood pressure is stable. Cap refill time is also less than 3 seconds, and he is fully alert orientated GCS 15. Then you look at the calves to see, is it any kind of clinical signs of DVT or any kind of edema anywhere, and you don't see any. Then you go on to take, a focus history, and then you find out that it occurred after a coughing fit, and ever since then he has not been able to maintain his oxygen saturations, and he's still at 83%, and he's been quite short of breath afterwards. He has this ongoing productive cough that he's saying he's got green sputum in it, and he has got a background of COPD with previous exacerbations, admissions with exacerbations, and he does not have any hemoptysis, just a good red flag to exclude and mention. So our patient, he's a 73-year-old. He has got a background of COPD. He is quite short of breath. He's using his accessory muscles to breathe. He has desaturated. So at this point, you would want to do an ABG on him. And I just wanted to mention why an ABG. When you would do it, an acute desaturation, for example, in this patient, and why would be, so most common would be COPD, or other risk factors for type 2 respiratory failure, such as hypoventilation from multiple factors. So person could be chronically hypoventilating from chest wall deformities or kyphoscoliosis. I actually saw a case like this last week where a young woman who had kyphoscoliosis, she was chronically hypoventilating, and she was, chronically in kind of compensated at this point type 2 respiratory failure, and she was using NIV at nighttime. Obesity, hypoventilation syndrome as well can make you more at risk of type 2 respiratory failure, severe asthma as well, drugs that can cause your respiratory drive to reduce, and any kind of cerebral kind of causes such as head injuries, causing that respiratory drive to reduce and you to essentially not blow off all that CO2 that you normally would. Two things to look for in an ABG: CO2 levels and your pH. Is it compensated or is it decompensated? I'll just talk a bit more about the ABGs. This is how I like to read ABGs. I know people have different methods of how to read them. I personally just follow this OABC mnemonic, and I think that works quite well for me. I was taught this in medical school, and it's just easy to remember, and I just kind of stick by it. So in an ABG, every time you do it, what I do is I look at O for oxygen, Normal values again, 10 to 13.3 kilopascals. Then I look at the CO2, keeping with that O theme. And then I look at for A. A is acidosis or alkalosis. I just looked at the pH next. Then B for buffers, looking at the bicarbonate levels. And then C. When I've looked at all of these, I should ideally start to get an idea of what's going on and if it's, respiratory cause or is it a metabolic cause, and is it acidosis or is it alkalosis, and whether it's compensated or not, and you would know by the bicarbonate and CO2 levels against each other. So again, this is, and I just wanted to mention this base excess. So you guys might, a lot of people are confused, and I wasn't really taught this well, and it was kind of just not really taught much in detail. But you will see base excess quite a lot and you'll be confused. But just know that -2 to +2 is in the normal range. And +2, that means you're having metabolic alkalosis. That means you're just having more. I would like to think of that as, more extra bicarbs. And then -2 is when you're going over to that acidosis side that like I associate minus with acidic and then +2 with, alkaline. So anything less than -2 would be metabolic acidosis, and then anything +2 would be metabolic alkalosis. This is a little flow chart just for you guys. So if pH is acidic, but the CO2 is up, so that's respiratory acidosis. If pH is acidic, but your bicarb is very, very low, then again, that's metabolic acidosis. And just to know if it's compensated or not, when you've got respiratory acidosis, if your bicarb is actually more than 28, that means it's starting to compensate. It's starting to increase in the blood to counteract all this, the CO2 and neutralize the pH bicarb as well. If you've got too low of a bicarb, then you will breathe faster and blow off all that CO2. So your CO2 will be less than 4.7 kilopascals. pH would be more than 7.4, so that's alkalosis. Respiratory alkalosis when you have too little CO2, and metabolic alkalosis is when you have too much bicarb. Again, when you have too little CO2, then your bicarb also decreases just to neutralize that pH. And metabolic alkalosis, when you have too much bicarb and your CO2 is again starting to increase just to counteract that. Again, just a little table for you guys to look at. Causes of respiratory acidosis, again, like we mentioned, hypoventilation, COPD, respiratory depression, respiratory alkalosis, not having too much, CO2 would be hyperventilating, blowing off a lot of CO2. Anxiety causes you to hyperventilate. Pain as well causes you to, hyperventilate, breathe a little bit faster. Metabolic acidosis, so essentially you're losing a lot of bicarb, things in DKA, renal failure. Your kidneys can make the bicarb or play a role in converting the it into bicarb. Diarrhea as well can cause you become acidosis. Alkalosis, so most common vomiting, and NG suctioning, diuretics as well. So we're just going to go back to our case. The 73-year-old male, short of breath, acutely desaturated. We've done the ABG on him. And he, is finding it quite hard to breathe. So at this point, because he's not maintaining saturations on Vermeer, we've applied a Venturi mask, 24%. It can go up to 28 too, so it's 24 to 28%. And we set his target oxygen saturations to be 88 to 92 to reduce the risk of depressing that hypoxic drive, essentially. We did his ABG and we find out that his oxygen levels are quite low, 7.9. His CO2 is 8, so he is retaining carbon dioxide, and his pH is 7.31, so he's quite acidic. And his bicarbonate is 32. That means he's chronically he's compensating for this type 2 respiratory failure. And his lactate seems to be okay, 1.4. Then you send off all these routine bloods just to check for, inflammatory markers, CRP, FBCs using EC, what his kidney functions are like as well. you notice the wheeze, so you want to start him on some nebs. Give him some salbutamol nebs, and also give him some ipratropium 500 microgram nebs as well, um, and saline nebs because he had a like if he had some. So saline nebs are usually used for people to clear out all their secretions. Um, if somebody's got a dry cough, then a saline neb won't be useful for them, and salbutamol for just wheeze. You look for a chest x-ray to essentially look for any infective causes for the COPD exacerbation. He probably would have had a chest x-ray, and now we know what the trigger of what his desaturation, his shortness of breath was as well, just a coughing fit. But again, chest x-ray just to make sure you rule anything out. If you already had a chest infection, just to see if there was any progression or essentially any other acute lung lesions, and always compare it with the previous ones. Steroids, so you want to start them on some steroids as well, like prednisolone, or if they can't tolerate oral, then you can, essentially step it up to IV hydrocortisone. Antibiotics only if it's indicated. So for example, if they're having a sputum and it's quite purulent, it seems looks very, very like there would be an infective cause to it. If it's starting to become green, as well, then just to follow your local guidelines, and most likely it'll be one of the three mentioned: doxycycline, clarithromycin, or amoxicillin. Other parts of the supportive management would be fluids to see if they're dehydrated. So you've started all of your kind of management. You've applied the Venturi mask to ensure they maintain their oxygen saturations. You've done the ABG. You've sent off the bloods. You've given some nebulizers for his wheeze. You've asked for a chest X-ray. You've started on some steroids that will also help with the breathing and the wheeze. Then you find that he's improved to 90% on the 24% Venturi mask. His rest rate has gone down to 24, and he feels less breathless. So again, he has improved. Um, when you want to consider NIV, so again, if the patient doesn't continue to kind of clinically improve, and you repeat the ABG and it's showing still pH is less than 7.35, and the PCO2 is rising, or if they were starting to become more drowsy or confused, then essentially you might want to you will have to escalate this, and then the Venturi mask will have to be switched over to a NIV mask. So that's more controlled breathing, and it's essentially just works by pressure to ensure that the carbon dioxide is exhaled as well. If the NIV isn't working either, then that's a senior, more of a senior and anesthetic escalation, and they will consider intubating and ventilating as well. Excessive oxygen, if the Venturi mask is not applied in this case, and you just apply 15 liters non-rebreathe mask, then ABG can worsen, and the CO2 can rise and the pH can drop, and that's quite worsening, and you're making the patient's blood more acidic as well, and patient becomes drowsy as well. That essentially just increases the risk of CO2 narcosis, is when your respiratory your hypoxic drive reduces so much, because your body thinks that it has oxygen, and you can essentially, the other extreme end to go to that would be coma and quite severely respiratory depression and confusion and things like that. So yeah, just a little slide on chest x-rays, what to look out for whenever you guys send off for a chest x-ray. Most important things would be to look for a pacification. So that just means whiteness in the chest x-ray film. Is it diffuse or is it patchy? And which lung zones do you see it? Or is it bilateral? Pulmonary edema as well. So blunting of the claustrophrenic angles and, fluids all the way up. So just that third painting. 1, 2, 3. So the middle painting at the bottom. Again, looking at the pleural lining, looking at the heart size, absence of lung markings as well. And also have a look at the diaphragm to see, is in COPD, you will have these diaphragms quite flat bilaterally. And also have a look for hilar lesions, mainly looking for lymphadenopathy. And then again, just part of, looking at the x-ray, look at the trachea as well, if it's central, probably one of the first things actually to look in a chest X-ray, and then ribs as well, just to see if there's any fractures. First patient, that first image on the right is just acute, just patchy opacification, highlighting kind of acute focal consolidation in the lungs. One below that is just hyperexpanded lungs. You can see the diaphragm's quite flat. That's just a COPD lung. Third one is that's essentially just pulmonary edema. You can see just some fluids kind of building up towards the lung. And then the one most left is aspiration pneumonia. You can see that the right bronchus is a lot more vertical than the left. So whenever somebody aspirates, the food goes down the trachea, it's more likely to go down towards the right bronchus and then kind of cause inflammation through there. So that's typical. That's what you will usually find in aspiration pneumonia, where the consolidation would be. Let's move on to the second case. So we've got a 68-year-old female. She presents to the emergency department with progressive shortness of breath over 3 days. So we know what the breathless patient, we know how acute this is. So this is over 3 days. This is not, fully within minutes or hours. This has been going on for 3 days now. You take a focus history, you find out that she has always been, feeling quite short of breath on exertion. Now she's, even at rest, she's feeling quite short of breath. She's been using 2 to 3 pillows at nighttime to sleep. She noticed that last night she just woke up gasping for air quite more frequently. She says that's been going on for months. Like, she'll wake up every odd once a week, just gasping for air, but now that has gotten a lot more increased. Ankle swelling for the last 2 weeks and just reduced exercise tolerance. She tells you that she could walk to the shops, but now she can barely just make it to her living room. No chest pain, no fever, no coughs. Past medical history, she had a cabbage 10 years ago. She's had multiple MIs in the past. She's type 2 diabetic. She has asthma, and she's got fibromyalgia as well. In terms of her drug history, she takes ramipril. In her past medical, she's also got hypertension, bisoprolol 2.5, and also atorvastatin. A2E wise, airways are patent. Her respiratory is 26, 90% on room air. Her SATs, and she just appears quite short of breath. Again, she appears to be using her accessory muscles. When you auscultate the chest, you find out that she's got crackles at bilateral bases. And then you look at her neck for JVP, and you find out that's, you can see a bit of elevation of that. Heart rate 110, so she's mildly tachycardic, and her blood pressure is stable. Pitting edema to the mid-sheens that now you notice. At home, she said she noticed her ankle swelling up, and now you can see that the edema is going up to her knee, or her shins. Bedside investigations. At this point, we're thinking, fluid overload, pulmonary edema. She has that significant heart history, multiple MIs, a cabbage. That essentially leads you to having, thinking of heart failure. In these cases, and in this case, she's coming in with shortness of breath. That's showing, and with fluid overload, that's showing it's decompensated heart failure, leading to pulmonary edema and peripheral edema as well. You will send some bloods off, including BNP as well, and a chest X-ray to look at the extent of pulmonary edema. This is the X-ray that you see. You can see it's completely fluid overloaded, bilaterally as well. Working diagnosis: acute decompensated heart failure with pulmonary edema. Immediately, what you do for this patient is you make sure that they sit upright, so all the fluid is concentrated at the base of their lungs, and it's not climbing upwards, causing them even more difficult to breathe. You want to set their oxygen targets to be more than 94%. You sent off the bloods, and then you will need to give her a kind of IV furosemide to immediately control her shortness of breath. 40 to 80 milligrams, um, depending on the weight, and previous use needs as well, to look at what the renal function has been like as well. Um, so these are the immediate kind of things to do as an FY1. Um, Afterwards, in your plan, you want to document to do strict input and output monitoring, so you can just and weight monitoring as well, so you can see how much fluid is being taken off her. Because we're giving her furosemide, that's nephrotoxic. So from now on, you want to just monitor her use and ease. Um, and if she's having, severe pulmonary edema, we could escalate that to a discussion, senior, sorry, and just discuss with them for any potential CPAP. So what that will do is essentially create, in pulmonary edema, the alveoli collapse, um, and they're not able to, maintain, take up all that oxygen from the blood because they're just fluid filled. CPAP just creates all that positive pressure and essentially helps with the diffusion and helps create all that, positive partial pressure that's needed for the oxygen to diffuse into the alveoli, from the alveoli to the blood. Um, and just think what could have triggered this acute decompensation. She's telling you that, I think she has got she looks like she's got heart failure, but if somebody acutely becomes short of breath, ongoing, and over the last few days gets worse, is there a certain trigger that could have caused this acute decompensation of her heart failure? Things like, for example, if she had already documented heart failure, was already on diuretics, already on the 4 pillars of heart failure medications, but now why is she decompensating? Could be because she's missing diuretics, could be because of an infection, also could be because of AF. So a new AF that people don't know that, and then they come into the hospital, and then they get their ECG checked, their pulse checked, and they realize that they're also in AF. A lot more in elderly patients when your risk factors of having AF is increased as well. Acute infection as well, MI, and uncontrolled hypertension can cause you to be in, decompensated heart failure. You do her bloods, you find out that the FBCs and CRPs unremarkable. Usually she's got a mild AKI. CRP is unremarkable, no infection. BNP is 1300. Again, just showing evidence of heart, ventricular muscle strain. And troponins are less than 7, so you just wanted to rule out any kind of ACS events. And then we move on to this third case, which is an ED. So this is, again, a 70-year-old female presents with shortness, sudden onset, shortness of breath, and right-sided pleuritic chest pain in ED. You take a focus history. You find out that she find out that the shortness of breath is quite sudden when she was walking to the bathroom. And she's also saying that she's having pleuritic chest pain in the right side of her heart, which is very, very sharp, she said. Also having dry cough. She had a flu 10 days ago. When you prompt her, she says, she coughed up some small streaks of blood. And background of hypertension, and her BMI is 34. She has also got breast cancer that she's undergoing chemotherapy for. You do the A2E examination. You find out that airways are patent, respiratory 27, 90% of her mare, chest is clear. Blood pressure, she's okay blood pressure wise, 108 over 72. Capillary full time is okay. Blood pressure is starting to be maybe a bit on the lower side, and she's quite tacky as well. It's alert orientated, and you look at her calves, and she has got some. She's not saying it's tender, but it's just mildly kind of right calf tenderness, but there's no swelling present. At this stage, after doing the history exam, A2E assessment, You send off the bloods. You do the FBCs using the CRP um, D dimer as well. I think at this stage as an FY1, you would send off the bloods. You would but then they take a while to come back. In the meantime, of course, you would do all your bedside investigations, so your ECG, your chest X-ray, and consideration of CTPA as well. I would, as an FY1, that's I think that's big kind of red flags for a pulmonary embolus. You do the ECG. Um, if we just go through the ECG together, you can see the rhythm is regular. She's very, very tacky. 300, 100, and 150. Um, 150. So about between 100 to 150. And no kind of ST elevations. And essentially just looks like sinus tachy. No left axis, right axis deviation, no kind of bundle branch blocks that we can see of any kind. William or no. You do the chest X-ray, find out that's actually completely normal. No acute opacification, no blunt costophrenic angle, no kind of lymphadenopathy present, trachea central, no loss of lung markings, and it looks like a normal chest X-ray. So essentially, you sent off the bloods, and now your ECG and your chest X-ray is just telling you, she's just sinus tachy essentially, and very short of breath. And she had this one episode of just vomiting up some blood. At this point, we're thinking PE, especially because she's got a history of breast cancer and her BMI is 34 and she's got hypertension. Risk factors for PE are there. And in PE, the chest X-ray and the ECG will just be all fine. I know we're taught that the S1Q3 T3 pattern isn't it's actually quite rare. Most of the time you'll just see sinus tachycardia. So we will book the CTPA, and then we just look at her Wells score. She scores a point for having her heart rate for more than 100. 1.5 points actually, plus 1 for hemoptyses, +1 for malignancy. We're not sure if she actually has signs of clinical DVT, because that would be +3. She's just mildly right calf tender, but it is unilateral as well, highlighting possibly could be a clot. At this point, as an F1, if you encounter a case like this, just quickly just work out with the well score, look at our PE risk factors, and even if it's not and you're not sure what could be causing this shortness of breath and just sinus tachycardia, and you might not even get all these cardinal signs, or the hemoptysis as well in a real life scenario, but just it's more of a clinical judgment. And at this point, if you think the patient is having a CTPA, book the not the CTPA, sorry, the PE, book the CTPA, and use the D dimer only if you think it's low slash intermediate probability. So you just want to book the D dimer because you're not sure. You just want to exclude it. So if you don't think it's a PE, but you just send off the D dimer, but most of the time we end up sending off the D dimer along with the bloods anyway. And yeah, D dimer is 2.0. The units are different in kind of different trusts as well. So it could be either 2.0 or 2000. Bloods are all negative. So yeah, if we think we've got a high clinical suspicion of a PE, we start them on immediate management, ensure that they're maintaining their oxygen saturations. We, again, just start them on anticoagulation. So that would be therapeutic low molecular weight heparin. It's different in every trust. So in my trust, we use enoxaparin. And you want to quickly discuss with seniors if they are around. And yeah, just make sure that they know everything. and they can help you through with kind of guiding what doses and the next steps as well, especially if you're still waiting for that CTPA and you've got a very strong suspicion, clinical suspicion of a PE. In terms of dosing, two options. So either you can do a twice daily regime of 1 milligram per kilogram subcutaneously every 12 hours, or you can just do 1.5 milligrams per kilogram subcutaneously once daily. Most common one is option one. If they've got renal impairment, then you calculate their creatinine clearance, because that's very important. And because the enoxaparin is essentially all renally excreted, so that would be good to work out. And if it's less than 30, then you just give them 1 milligram per kilogram once daily. And just continue to reassess their hemodynamic stability. Big red flags to, for a PE, and that requires immediate escalation, is if they're becoming hypotensive. So essentially a massive PE that is causing now a right heart strain, obstructing that blood flow from the right ventricles all the way up to the pulmonary vessels, and now it's causing all that backflow, causing you to have peripheral edema, so elevated JVPs, and essentially just signs of right ventricular strain and peripheral edema as well. That's or having syncope and having a rising lactate as well. That's massive PE indications, and that's immediate escalation. So I've discussed, 3 cases: COPD exacerbation, pulmonary embolus, and pulmonary edema, which I think are probably the most common ones, but there's also other ones to think of. So asthma, pneumonia, pneumothorax as well, pleural effusion, and then also just think of cardiac causes, acute heart failure, again, just as a result of pulmonary edema, and then arrhythmia, ACS, metabolic causes of breathlessness, anemia, that would be, chronic, feeling quite short of breath, metabolic acidosis, you're trying to blow off all that CO2 to counteract that acidic pH. DKA, when somebody has DKA, they have these signs of Kussmaul breathing, which is, deep breathing and fast breathing. You're again trying to blow off all that CO2. That can cause you to be breathless. Just have these in the back of your mind for, non-respiratory and cardiac causes of breathlessness, especially anemia and metabolic acidosis, which is essentially DKA as well. Others would be anxiety. It's very important whenever, a lot of the times on my on-calls, I've been asked to go assess patients and they're very, very, short of breath. They look like they're working hard to breathe. They look like they're using their accessory muscles, but you get there, you find that there's actually no that there's no changes to their oxygen levels. If they were on oxygen already, they haven't actually desaturated. There's no increase in oxygen requirement. Or they're still on Romer. They're not wheezy. There's no crackles, but they're very, very just short of breath. And I think the more cases you see, the more you will, look at and like kind of other causes of breathlessness, things like anxiety, or pain, as well. Um, in those cases, you might, like, I've discussed it, in actual war scenarios. I've discussed it with my seniors, and they recommend some morphine, or small doses of lorazepam, just to help them calm down, and and if they do, and if they're feeling a lot better in terms of their breathing, then they could be, it was essentially just anxiety driven. But then again, this is on a respiratory ward. We already know kind of what's the causes. They probably came in with shortness of breath, cough, wheeze, fever, stuff like that. And now when they become acutely short of breath, they might not actually have a pathological etiology behind it. They could just be, very, very anxious, as well. And just deconditioning. That just means whenever patients are in the hospital for a long time, they're not mobilizing much, and they are not really using their muscles much to, again, kind of move around as well. Can cause you to have be kind of short of breath as well. That's more of elderly. That's a whole kind of other topic to kind of discuss. These are some kind of, I've only gone through 3 conditions, but again, COPD exacerbation, very similar to asthma exacerbation management. You give back-to-back saline or salbutamol and ipratropium nebs, and then you reassess after all the nebs to see if their wheeze has gone down. You also give steroids as well. If that's not working, then you escalate and you can consider IV therapies like IV hydrocortisone or IV magnesium therapies as well. And again, just look for any infective causes of asthma exacerbation as well. Pneumonia, and if you are looking for any infective causes, most good idea to send off COVID flu, extended respiratory viral screen, sputum culture as well, ONS as well. Pneumonia as well. If they're desaturating, give them oxygen. This is very broad, kind of how to deal with all of these kind of scenarios. Essentially, IV antibiotics and fluids if they're dehydrated as well. And a lot of the time when people come in with pneumonia, they've got very increased reduced oral intake, and they're quite dry and dehydrated. So when you assess their mucous membranes, they're very dry, and you just want to ensure that they're having enough oral intake, and also any kind of risk of AKIs as well. Pneumothorax. If you're not suspecting tension pneumothorax, then you do a chest X-ray, and you find out if it's essentially primary or secondary. If it's primary, you do the chest X-ray. If it's less than 2 centimeters, conservative management. If they're secondary, again, so they've got risk factors, COPD. If it's less than 1 centimeters, conservative management essentially. Or you can kind of start to think of kind of how to essentially just needle decompression or aspiration. Clinical sign, or just, and if someone's short of breath, these are some signs to look for: attention pneumothorax, hypotension, tracheal deviation, which you can feel, distended neck veins, reduced breath sounds, hyperresonant chest, and it's a clinical diagnosis, do not work for the chest X-ray in this scenario. Again, anemia. This can sometimes be missed, but again, that would present with kind of chronic shortness of breath, chronic tiredness, with also other symptoms as well. Thresholds for transfusion, less than 70 usually for all of the patients, everyone. But if they've got a cardiac history or in an ACS, then that threshold is a little bit higher, of less than 80 as well. Red flags, suspected kind of conditions to immediately escalate and manage at the same time. Tension pneumothorax, massive PE, like I said, pulmonary edema with severe distress. That could, the CPAP, you might have to consider that. And just last of all, I want to discuss some oxygen therapies that I think is quite undertaught. I've made a little flow chart. As you go across along the chart, it's increasing in terms of the amount of oxygen that you're giving. So the lowest form of oxygen we can give is via a nasal cannula. That can give about 1 to 5 liters of oxygen. And your FiO2 would be 24 to 44%. Sorry. And then the next step up of this nasal cannula would be just a simple face mask that delivers a bit more oxygen, about 5 to 10 liters. And then your FiO2 would be increased a little bit to 30 to 40% saturations. So the indications for a nasal cannula would be mild hypoxia, and if the patient's stable, and / if they're a ward patient as well, they're just requiring a little bit of oxygen to maintain their oxygen saturations as well. And then the next one would be simple face mask. Like I mentioned, indications for this would be moderate hypoxia and just short-term oxygen therapy. Next, you move on to the Venturi mask. So again, that gives you fixed rates of the FiO2 that you can control via the adapter. You know, the different colors of adapter, the green, yellow, blue, orange. Um, Depending on the size of the adapter, you can control how much oxygen is actually going in um, to the patient's airways. Indications, again, COPD, like I mentioned, when precise oxygen FiO2 is needed, delivers the constant FiO2 regardless of the patient's respiratory rate and their flow pattern. Step up of that one, or not essentially, Venturi pass is just, a specific type of oxygen delivery. Step up from the next kind of oxygen delivery would be non-rebreathed mask, giving you 5 to 10 liters of the flow rate of oxygen. FiO2 could be up to 90 to 95%. Um, Indications of that would be severe hypoxia, shock or trauma, or just before intubating. This non-rebreathe is essentially a lot better than the simple face mask because the oxygen that you're breathing in is not mixed in with the oxygen around in the environment. It ensures that all the oxygen that you're breathing in is coming from the source itself. There's no mixing from the environment. That's kind of how it's made with the bag. Whenever you apply it, the bag will also kind of fill up, and then you're essentially breathing in oxygen from the oxygen source and also from that bag, but that also only contains the what's the word, the controlled level of oxygen. So the FiO2 is essentially in that bag is 90 to 95%. High flow nasal cannula. So there's two types of cannulas. There's the normal one, and there's the high flow one. Can give you flow rate of up to 60 liters per minute, and your FiO2 can increase to up to 100%. Yeah, the indications for that would be acute hypoxemic respiratory failure. For patients that are simply not tolerating the oxygen mask, some people don't like putting on the oxygen mask. They don't like it. It causes them a lot of suffocation. So this is also a great option for giving high levels of FiO2. Essentially, again, BiPAP/CPAP. So that's your non-invasive ventilation. So that's controlled, constant positive pressure. FiO2 can be up to 100%. Like we mentioned, COPD exacerbation, cardiogenic pulmonary edema, and moderate respiratory distress. Sorry, and that is all pressure related, all pressure based, and you can vary that, so you can really control how much that they're taking in. So two other types of giving oxygen therapies, your bag and valve. So essentially, these two options are something that you mechanically, have to ventilate and give the patient yourself. It's not, like in that constant device that gives them the oxygen. Bag and mask, that's so that your ambulatory oxygen gives when you attach the bag, and then you're essentially pressing the bag every 6 seconds and manually giving the patient oxygen. So that would be up to flow rate would be 10 to 15 liters. FiO2 can be 100%. In certain scenarios like apnea, respiratory arrest, and in the community as well, when somebody arrests and they've got respiratory arrest, so we give them ambulatory oxygen in the meantime. Mechanical ventilation, your anesthetic anesthetist would do that, and again, FiO2 all the way from 21 to 100%. And it's controlled if your NIV doesn't work, if you've got a low GCS, or if you're arrested, cardiac or respiratory arrest. So yeah, I can actually add a little slide at the bottom if you guys want the slides for this, just to have a bit more information about all the indications for these different types of oxygen delivery devices. So again, just a step-up approach that you for all of these oxygen delivery devices. I myself is learning in the respiratory ward when I get confused and how to look at what oxygen mask is the patient on and what's changed over time and why are they on this specific delivery device. sorry, one other method that I didn't mention was airvo. Um, that's essentially just humidified, high flow, simple face mask. But that's because when you're giving oxygen, that can cause your nasal passages to be quite dry. So the humidified oxygen just essentially delivers kind of humidified oxygen to your airways, because that will just be a lot better for patients. And whenever people have dry airways and nasal passages, that increases their risk of having nosebleeds as well. But yeah, that's just a variant of all of this. You can add humidify to all of these methods. Um, Practical word tips again, just last slide. Um, Reassessing frequently after interventions. Whenever you've made an intervention, especially giving nebs, assess how if they've improved in their wheeze. And also their if you've given diuretics, then assess how their breathing has been as well, and do daily weights afterwards to see how much fluid you're taking off the patient. Um, and always, when you're looking at chest x-rays, always pull up the last chest x-ray to compare it with. Um, and document your escalation plan early. Whenever you're handing over the patient, it's a good idea to just document in their notes what you want the patient, what you want the management for that patient to be if they deteriorate, because you were the first person to see that patient, and so the next team will be a lot more in tune with what you want to do and what happened earlier and why they want it done a specific way. Analgesia for pleuritic chest pain as well. That can sometimes be missed. Again, over oxygenating COPD patients, missing sepsis as well. But yeah, that is it for my presentation. Um, Let me know if you guys have any questions, and I'm happy to answer them. But yeah, thank you so much, guys, for listening, and I hope that made sense. Sorry, I only went over 3 cases, but I just wanted to go over them in detail, and different things to kind of immediately manage, and what to do in certain scenarios when the bloods aren't back, and when the ECG and chest X-rays are showing, and what to kind of go from there. Um, but yeah, thank you for listening. And here's the QR code, just if you guys wanted to fill in for any feedback as well. But yeah.